So today's presentation is Tissue or Mechanical, an informed discussion on surgical valve selection. This is sponsored by Edwards Life Sciences. We've got three speakers this evening. Dr. Nikhil Bassi, he's from Hoag Memorial Hospital Presbyterian. Dr. Patrick McCarthy from Northwestern University Feinberg School of Medicine, and Dr. Matthew Romano from the University of Michigan. Before we get started, we want to go through a couple of housekeeping items. First of all, we are going to be monitoring Q&A during the session. If you have any questions, please, there's a little button on the bottom that says Q&A. Please enter your questions there. We'll be monitoring those throughout the presentation. And probably at the end of the webinar, we'll be presenting those to the panelists. So I think we should be all ready to get started. We're going to begin with Dr. Nikhil Bassi on his presentation. I'm going to turn it over to you, and thank you all for joining.
Well, thank you, Chris, and thank you all for participating. And we're very excited to talk about an issue that we see, very commonly in our practice every single day. And so I'm a clinical cardiologist, and I know a lot of the people in the audience are seeing these patients in a cardiology type practice. So today we're going to be discussing valve selection for the cardiologist's right valve at the right time. And these are my disclosures and the disclaimers. So here's a common case that, comes up very routinely, right? So you have let's say a 61-year-old male, bicuspid aortic valve with severe stenosis and otherwise pretty mild comorbidities, pretty healthy guy otherwise. He has an active lifestyle and wishes to avoid anticoagulants, but he also wishes to avoid reoperation. And so he's looking to you as the cardiologist for guidance as to what the next step should be. So we're going to be talking a lot about the guidelines, and just recently the European Society of Cardiology released their valvular guidelines, and they included this figure, which I thought was a good summary of the different options. And so the different kinds of valve replacement operations or procedures. So on the one hand, you have the Ross procedure, which is actually coming into vogue. Some limitations there, technical complexity, and they recommend, centers of excellence that are doing a high enough volume. Probably a good option for younger patients, and perhaps we can discuss further in the Q&A session. Certainly, mechanical valves are, a relatively common choice. Potential limitations there, of course, would be needing to take an oral anticoagulant. And then you've got bioprosthetic options, whether that's a surgical AVR or a TAVR, and some potential limitations there would be limited durability depending on, when it's done, and we'll get into that. So just, from a broad perspective, there's a variety of different options that, to discuss with the patient. And so what are some initial considerations if we decide to go down a bioprosthetic route? What would be some things to kind of think about? So if the patient is less than 70, typically we've favored a surgical AVR. That's changing over time, but that's sort of, where the guidelines are today. Some reasons why we might want to do a surgical AVR versus TAVR would be if a patient has a hostile annulus, bicuspid valve like our patient, or annulus dimensions may be unsuitable for TAVI or risk of coronary obstruction. These would be reasons why we would consider maybe a surgical AVR over TAVR. Some other things that might favor TAVR would be if a patient is frail or has significant comorbidities, which would increase surgical risk. But the bottom of this slide is, I think, the key point of my talk today, and that's lifetime management. So we don't just refer our patient for a procedure. We've got to manage the patient for years and in some cases decades after the procedure. So redo SAVR, there's obviously a risk of redo surgery. You could do a SAVR after TAVI, but there's increased risk, and we'll be maybe hearing a little more about that. And then, of course, valve and valve. And, what are the potential pitfalls associated with that, including patient prosthesis mismatch. So we've got to factor in not only what do we want to do now, but how do we guide the patient moving forward in the years to come. So what do the guidelines currently recommend? In the United States, if a patient is over the age of 65 for aortic valve, recommend tissue. And if the patient is significantly younger than 50, then mechanical for aortic, and then kind of a wide range in the middle. Either option is allowed, and patient and physician shared risk management conversation. And the European guidelines, they have a mechanical recommendation up to age 60, and they share tissue over the age of 70, and sort of in that, or actually 65, but in between 60 and 65, guidelines don't really specify. So again, patient and physician shared decision-making process there. So what are the trade-offs? If now we're thinking bigger picture here, mechanical versus bioprosthetic valves, right? So mechanical valve, theoretically, it's a one and done. So durability is a potential advantage there. But the disadvantage is lifelong anticoagulation. So this is a conversation we have to have with our patient up front. Say, hey, if we're going to have a mechanical valve, you're going to need to be on warfarin for the rest of your life. And in those instances where reoperation is required, there's no valve-in-valve option. So we're talking another surgery. Bioprosthetic valves, no anticoagulation. We have valve-in-valve as an option potentially in the future, but higher likelihood for reoperation depending on age at implant. And so I think it's important to be fully transparent about the trade-offs right up front before we even really refer to the surgeon. So, again, this is up to date 2025. Bowdish et al. Published, an excellent paper recently where they looked at over 100,000 patients in the STS registry, and they looked at all-cause mortality after adjusting for certain risk factors. And I added these vertical lines at 50, 60, and 70. And so, if we look at over the age of 70, I think it's clear that all-cause mortality favors bioprosthetic. That kind of makes sense and goes with the guidelines. Younger than 50, it shows clearly there's a benefit for mechanical valves, all-cause mortality. Between 60 and 70, you can see that the confidence interval crosses 1. And so this is where there's equipoise and we have that shared decision making. Now, less than 60, it does appear that there is, a potential reduction in all-cause mortality with the mechanical valves. And so I think that's an important signal for further investigation. Now, what are some potential limitations? Number one, what is the role of bleeding complications? Two, if we look at this registry, it was from 2008 to 2019, median follow-up of 5.4 years. What about valve-in-valve as an option? And how has that changed between 2008 and where we are today? I think patient desire, so again, that's a critical aspect that we want to highlight. Is taking warfarin something that patients want to do? Maybe, but many of them do not. And then limited follow-up. And an oral anticoagulant gets more difficult with age. It's one thing if someone is, say, 60 and they're put on warfarin, but what about when they're 80 or 85? That becomes exponentially more challenging. So we talk about bleeding complications. Here's a study that looked at that age less than 60 population. And what we can see is that mechanical valves, so that's the red, you see there's a much lower risk of reoperation, kind of makes sense, but there's a much higher risk of bleeding and a much higher risk of cerebral stroke. So although that may not factor into all-cause mortality, these are still clinically important endpoints for our patients to consider. So summary of the guidelines and clinical data. I think age less than 60, either one is allowed, although European guidelines do emphasize mechanical valves. Age greater than 70, bioprosthetic valve is clearly preferred. And then between age 60 and 70, there's no great evidence either way. It's a trade-off. On the one hand, with mechanical, we've got a risk of major bleeding and taking warfarin versus bioprosthetic risk of reoperation. So we're involved every step of the way, and this is the lifetime management of the patient. So what do we have to do before, during, and after? Monitor for signs of valve deterioration. We need to make sure if we do choose a mechanical valve, the patient is compliant with warfarin and the INR target. We've got to monitor actively for bleeding complications. If a patient needs surgery in the future and they have a mechanical valve, we need to be managing perioperatively their INR and potentially bridging with Lovenox. And of course, if a patient is active, sports and hobbies, how do we navigate that? And so, what I like to do in my practice is I like to discuss some of these trade-offs prior to referring to the surgeon. And I always say, we're not going to decide today what the best course is, but here's some information, some things to consider. And when you meet with the surgeon, let's touch base afterwards before we schedule and make sure everyone's on the same page, because this is management for the rest of our life. And just a word about compliance with warfarin. We think it's easy. It's not so easy, right? So in this study, they looked at patients that had a time in therapeutic range of greater than 70% versus less than 70%. And you can see that the patients that had greater than 70% had a much lower risk of thromboembolism, which makes sense than those that had less than 70%. But 2/3 of patients are less than 70%. And the mean of was about 59% of them. So you can see that time in therapeutic range is not a straightforward thing. And when we do mechanical valves, we've got to be careful that patients are actually able to stay within that range. If they're not, their risk of complication goes way up. So, in summary, there's no one best solution. This is a lifetime discussion with the patient. And I think all options are on the table for our patients. And so, in our patient, a 61-year-old gentleman with a bicuspid aortic valve who has an active lifestyle and wishes to avoid long-term anticoagulation, I think bioprosthetic valves would be a viable option. Not the only option, but I think a great choice, and especially with advances in valve and valve technology. And so with that, I look forward to taking your questions a little bit later, but I'll pass the baton on to our next speaker. Thank you.
Thank you, Dr. Bassi. And so I'm going to talk a little bit about bioprosthetic and mechanical mitral valve replacement. How do you decide? What I want to accomplish over the next couple minutes is provide you with current data and information that will help you in the decision-making process with the patients. Here are my disclosures. So I just briefly want to go over this again. U.S. Guidelines on the screen there. The cutoff for valve replacement is 65 years of age. So if you're less than 65, you get a mechanical. If you're greater than 65, bioprosthetic. In Europe, the cutoff is 70 years of age. And I want to dig into the data on this a little bit more and help everyone understand the data and how to use this in educating patients and helping you make decisions as well. Next slide, please. So let's look at this paper, and this has received a lot of press. And this, in fact, is used to create, as one of the references that is used to create both US and European guidelines. This was a large administrative database study that looked at both aortic valve and mitral valve replacement. I'm just going to focus on mitral valve replacement. And what the main conclusion was is that there was a significantly higher mortality with receipt of a bioprosthetic valve, and that persisted until 70 years of age. And there's some significant flaws with this paper that I'd like to point out and should also make you critically consider the current guidelines. So if you look in that bottom left graph there, you see that there is double the mortality at 30 days for a bioprosthetic valve compared to mechanical valve. That should tell you something. Why should there be? No prospective randomized study has ever demonstrated a difference at 30 days with mechanical or bioprosthetic valve. And the reason why this is different is important as we get into this paper. Next slide, please. Um, some of the additional findings of this paper is that a bioprosthetic valve was associated with a significant lower incidence of stroke and bleeding than a mechanical valve. And if you had a stroke or bleeding event, that was a significant risk factor for death. So the main questions here are if stroke and bleeding are lower with the bioprosthetic valve, yet mortality is higher, why is that? And the reason is, I suspect, and I think it's borne out in the data, is that due to reoperations or a matching problem. And indeed, in that study, the 30-day mortality after reoperative mitral valve replacement was a staggering 14%. I mean, that is really impressive. That's more than double what you would expect to see in the SDS prom. Okay, and then some of the limitations when you're looking at matching, some of the limitations of the SDS prom are that they don't account for certain characteristics of patients, such as drug use, social determinants of health, liver dysfunction, frailty, cancer, people who are wheelchair bound. They are going to get a bioprosthetic valve. So the STS is really good at looking at the middle of the bell-shaped curve, but doesn't really account for some of these other factors. And I think this factored into the findings that we saw in this paper in terms of a selection bias and problem with matching. Next slide, please. So let's look at this paper. This is another large database paper which looked at similar age groups and compared mechanical and bioprosthetic, and they did not find a survival difference at 15 years. Next slide, please. Like the study that I just went over, similarly what they did find is that mechanical valves were associated with higher incidence of stroke and bleeding events, which you can see in the graphs here. And if you did experience a stroke or bleeding event, your mortality was significantly higher. Next slide. And if you did need a reintervention, so a reoperation, you didn't pay a mortality penalty like we saw in the last study of 14%. The reoperative mortality was low at 5.3%. And this seems like it's more real-world data. Next slide, please. So what can we say about bioprosthetic durability in the mitral position? Well, this is a study that we published. This is a collaborative retrospective study between two mitral reference centers, University of Michigan and Northwestern. And what we did was over a 16-year period of time, we looked at patients retrospectively that underwent a mitral valve replacement with a bovine pericardial prosthesis, primarily all of which were under the Edwards platform. Next slide, please. And what I want to point out in this slide is we divided the patients based on age, so on the US guidelines, so greater than 65 and less than 65. And over 40% of the patients were under 65 years of age that underwent implantation of a bioprosthetic valve. So you can say we violated the guidelines over 40% of the time. And when we look at this, the two critical questions that come to our mind is what is the need for re-intervention and what is that risk? Well, overall, only 4.5% needed re-intervention for structural valve degeneration during the entire study period. So not bad, pretty low. And what we did was we separated it by decades. And here I show the 40s, 50s, and 60s. And what you see both at 10 years and at 15 years, pretty similar. And those graphs, lines really aren't changing. And if you go out to about 15 years, it's only about anywhere from 15 to maybe 25% chance that you may need an intervention for structural valve degeneration. Next slide, please. And in our series, reoperative intervention for structural valve degeneration was again low at 5.6%, similar to the study that I just reviewed with you. Next slide. I think it's important, and Dr. Bassi mentioned some of this about the valve and valve of the era that we're currently in. There's newer tissue preservation technology with the promises of prolonged durability, and also the valve and valve, which is becoming more and more popular option. Next slide. And this is data regarding valve and valve. This is over a 6-year period of time. This is data from Northwestern that looked at mortality following valve and valve. And if you look at the STS prom, which was 4.6% for these patients, the actual mortality was only 1.35%. So you can do this reintervention with a very low mortality rate. Next slide. I like this slide because oftentimes I'll have a patient that will come to me and we're talking about valve replacements if that's what they need. And they say, well, they tell me that a bioprosthetic valve is only going to last 8 or 10 years and then I'm going to need another reoption. Well, not really. So the first valve and valve was done in 2009 and it was approved by the FDA in 2017. And if you, based on the data that I reviewed here, if a patient undergoes a implantation of a bioprosthetic valve today, 2025, if they're having a really bad day, it lasts 15 years. Or potentially 20 years if they're having a better day. But if a really bad day, 15 years. And at that point, you can offer them a reoperation with very low risk or a valve and valve with very, very low risk. Next slide, please. I think what's important to focus on is that at the end of the day, this is a shared decision-making process. And that is a class 1 recommendation. I think it's reasonable to suggest and advocate to remove age as a cutoff. And I think having such a strict cutoff on age can be potentially detrimental. The factors to consider and to discuss with patients are their comorbidities, other need for warfarin. Do they have a prothrombotic state, for example? Their age, lifestyle, what type of activities they do, their work, social determinants of health, and any upcoming surgery, renal transplantation, for example. And we have to remember that we don't live with the decision, the patient does. And I got to believe that most people, if given a choice and asked, would they like to take Coumadin, most people would probably say no. Next slide, please. Thank you.
Hey, everybody. It's Pat McCarthy. I'm trying to get my video to turn on. Hopefully it will be soon. I'm going to take a little bit of a different approach to this. I'm also going to throw in transcatheter aortic valve replacement as one of the decisions, just so that we're really kind of up to speed on what the patient discussions are going to look like. My disclosures are at the bottom of this slide. Can I have the next slide? These are the disclaimers. You've seen these from the prior speakers. So the guidelines are based on age rather than risk. And in a lot of ways, that's a mistake. And you just heard from Dr. Romano that we have to take into account the entire patient when we make those type of decisions. Because if you are a patient that is 60 years old with multiple comorbidities, then your life span may be reduced. And it's more than just your age. And also they may have other factors that are going to impact that. What I wanted to point out with this is that this is looking at age versus TAVI discussion. And the ESC just about 2 weeks ago moved the decision-making down to age 70. Can I see the next slide? So they had said that below age 75 that the patient should have a surgical aortic valve replacement, but now they've moved that down to age 70. The American guidelines already had that at age 65. So below 65, most of those patients should be having a surgical aortic valve replacement. Next slide. The considerations, as they pointed out in this, is that if it's a low surgical risk, that's a patient that would be better served in most cases by surgical aortic valve. High surgical risk, obviously the TAVR, we heard the partner in other early trials pretty well documented the benefits of TAVR in that group of patients. And then also if they're just not good candidates for patients for TAVR, like the unsuitable anatomy. And if they're going to live less than 10 years because of comorbidities, that makes the patient more eligible for a TAVR. Next slide, please. So, but it's interesting how this is not really permeated very well. So on the left, you're looking at data from California, less than 65 and even less than 60. And what you see here is that TAVR, even though at age 65 and less is recommended only for patients over 65, a lot of those patients were getting TAVR like 45, 47.5%, and the same in New England. In Europe, it's quite different. So if you see France and Denmark, and then just out of curiosity, last week I had them run the data at Northwestern, and we're somewhat in between. About 28% of patients less than 65 were getting TAVR. So it may well be appropriate in a group of patients that have significant comorbidities. But it's very interesting, and maybe with Dr. Bassi later, he practices in Southern California. We'll talk to him about that decision-making in California. Next slide. So I wanted, instead of just giving you a series of slides and a series of different publications that are out there to really begin this sort of discussion. So maybe Matt and Nikhil, if you guys want to go back with your cameras on, we'll begin this discussion. So in Nikhil, and you in for particular, these are the kind of discussions that we as surgeons are having or thinking about with our patients. So this is an example of a 60-year-old patient who has severe aortic stenosis, a bicuspid aortic valve. The indication is that in California, it's almost a 50-50 chance whether that patient may go for TAVR or whether they may go for surgical aortic valve. Talk to us about what that decision-making feels like in California.
Absolutely. Well, I think, part of it is just sort of cultural and patients, it sort of feeds on itself. So I think, patient's neighbor got a TAVR for perhaps a totally different indication. And now, that's what I want to do for my valve. And so part of our job as cardiologists is to go through the data, go through the guidelines. And anecdotally, I have had patients who come to me after getting a TAVR and they have a bicuspid aortic valve and they're doing great. But if you look at the trials, most of the time, bicuspid aortic valves were excluded from those trials. And that's really where they don't really recommend at this time, for as a standard recommendation that a patient with a bicuspid aortic valve, as an example, should be getting a TAVR.
I think that's important to point out. Matt, by the way, if you can come on camera, the next series of questions are going to be for you as well. The bicuspid aortic valves, there are series where they're successfully treated with TAVR. But I think what they're looking at is the maybe 20% of patients, especially these young bicuspid aortic valves where the valve is really heavily calcified. And it would be difficult to treat them with TAVR because of the eccentricity of the orifice and all. But you're reflecting real world. People come in and they say, my next door neighbor or my cousin or someone had a TAVR and went home the next day and they felt great. Therefore, that's what I want to have. So, but it's interesting. People don't feel bad about, they know they're going against the guidelines, I would assume. And so they just think that's okay.
I think so. I think everyone, you don't go into this business unless you think you're the best or amongst the best, and you go, well, those are the guidelines, but here's what we do in our practice. And I think there's value, but at the same time, okay, what does the evidence really show? And again, lifetime management. Are you going to do a valve and a valve and a valve and a valve? I mean, at some point, you reach the law of diminishing returns. If you do surgery, now you have a good platform to do a valve and valve in the future.
Yep. Thanks. So Matt, for you, let's say that the patient wants to have a tissue valve, a surgical aortic valve replacement. Talk us through our decision-making as surgeons in 2025. It's very different than it was 10, 20 years ago, before we were always thinking of lifetime management of the patient and what size valve that we're going to put in. Is it going to be able to accommodate valve and valve in 20 years when that valve may wear out, and the frequency of root enlargement?
Yeah, so again, I mean, I first begin with, looking at the patient and understanding the patient and, their overall, um, all the factors that go into it, their lifestyle, social determinants of health, some of the things that I mentioned before. And at that point, I think we're getting better and better durability. The current valves that are in trial are very promising. So that goes into the fact decision-making process and factoring in as well. Um, in the era of valve and valve, um, in my mind, I'm always thinking effective orifice area and minimizing any possibility of patient prosthesis mismatch. So I look at and I discuss with the patient the possibility of a root enlargement. And then it becomes a math problem, and I figure out if I can get a decent size valve in there, and it's going to be so. If it is, say you're 50-year-old, and we say it lasts 20 years, and we can do a valve and valve in 20 years, um, and you get a good size valve in there where you can put pretty much the largest transcatheter valve in the stented bioprosthetic valve, and say that lasts 10 years. Well, now the guy's 80, and you still have enough of an orifice area to put in another transcatheter valve, and hopefully that should last him the rest of his life.
Yeah, I think things have changed a lot, and we are really clearly thinking about, what's going to be the 20-year future for these patients when we operate on them as surgeons. I can remember being in the back of the room with some of my, at the time, older colleagues, like 30 years ago, and they would say, I'd have no hesitation to put a 19 aortic valve replacement in a patient that was 75 or 80. That's pretty much anathema now. We rarely would put in a valve less than a 23, and especially the bicuspid aortic valves, they average to be about a 27 valve. So there should be plenty of room for that patient group to undergo later valve and valve
I
when they
think it's,
go through that.
Pat, I think it's important too, what you do the first time around. So I have seen some people who I would consider relatively young that have undergone a transcatheter aortic valve replacement first time around, and that has failed. And then what is the next option? Do you do a transcatheter, another transcatheter valve and valve in someone who's in their 60s? Or do you do a replacement? And the problem with doing a replacement, which I personally think is the right way to go, is to do a surgical valve. But that operation is a lot more complicated now than it would have been the first time around. And I have young patients that come into my office and will say, "Hey, what about the through the groin valve? I want that one." And so you really have to have a conversation with them to plan out their life to help them to realize why is beneficial at different stages of their life.
Nikhil, tell me how well cardiologists understand durability of tissue valves. So it surprises me that even today, I'll have patients that come in to see me and they may be 65 years old. And they say, oh, my cardiologist said I shouldn't get a tissue valve because they only last 8 to 10 years. That was true in 1972. I've actually hesitated to ask them how old their cardiologist is, but we just saw the data from Matt showing, especially if you're like 65 years old and 70, almost never do those patients have to really go through a reoperation, and even down patients in their 50s in the mitral position, and that wears out earlier than an aortic valve. At 10 and 15 years, you're looking at about 15 to 20%. So 70, 80% are still working and haven't needed a re-intervention. Do you think in cardiology this is pretty well understood, or do a lot of people still hear those old stories from first generation tissue valves?
It's an excellent question. I think in training, we're still taught that the bioprosthetic valve lasts up to 10 to 15 years. That's sort of the teaching. And then when you're in clinical practice, you see that, just as you said, that's not necessarily the case at all. I think in practice, we're really favoring the bioprosthetic valve. So if you look at that Bodish analysis, in the 12-year study, they said that mechanical aortic valves went from about 20% of the population in 2008 to less than 10% in 2019. So I think the trend over time is that we are really favoring these bioprosthetic valves more and more. And so I do think that there is generally a pretty good understanding over time, but I think it's worth reinforcing that these valves have excellent durability, and the valves of 20 and 30 years ago are not being implanted today.
Yeah, it was one of the points that Matt made, and in our joint publication between Northwestern and University of Michigan, nobody had really published such a large series of mitral valve tissue valves, and we were pleasantly surprised. I actually kind of thought so because I just didn't see many patients returning for reoperation, but then overall only 4.5%. I'm glad you brought up the Bodish paper. This is a paper that was published about 6 months or so ago, and it is looking at mortality in patients with tissue and mechanical valves. It's a good study. There's about 109,000 patients, and only about 15,000 of them have mechanical valves. And for the group of patients less than 60, they did show some survival benefit, but they were also, as an administrative database, they weren't able to show things like complications from the Coumadin, bleeding, stroke, et cetera. And the average follow-up was only about 4.5 years. And so, these patients are going to be on it for their entire life. And, we don't really know what that's going to look like over time. I don't know about you two, but patients don't generally show up and have read, the number of papers that we just went through, and they don't even seem to know that much about the guideline. But what they do seem to know about is Coumadin, and they just seem pretty averse to being on Coumadin. So that's the next one. What if the patient is a skier? They just say, "I just don't want to take Coumadin." That has to influence your decision making and your discussion with them, I would assume.
Absolutely. And, every now and then, sometimes the patient doesn't really understand what Coumadin entails. They say, well, I've sort of heard of it, but once they understand, well, I have to get my blood checked every week, and there's certain vegetables I can't eat and medication interactions. And if I need a non-cardiac surgery in the future, I might have to bridge with Lovenox. And those are not insurmountable obstacles, but it's important to be really transparent up front and make sure that they're fully aware of, the full gamut of what being on one medication really entails. It would be great if there were other options, but they've studied this, and as far as I can see, there's really warfarin is still the only option in mechanical valves.
Yeah, unfortunately, the others didn't work out as well as they had hoped. So basically, Matt, how low do you go? What if it's, the 30-year-old patients that were in our series, a lot of those were women of childbearing age, and they wanted a tissue valve just because that's safer for, the mom and the fetus. I was surprised when I've looked at that data just how high the maternal mortality is for women that have a mechanical valve. Do you consider a Ross procedure in some of these patients, like when they're less than 60 or 50? When do you think that might be appropriate?
Yeah, I think that's a great point. And what I have seen, at least at our meetings, I personally don't do Ross procedures, but it seems like there has been a resurgence in the popularity of Ross procedures. And I think that my understanding is always it's the younger you can do it on a patient, the better. Um, uh, I think it needs to be done at a center of excellence because there are nuances to it, and it's if you're only doing one every couple years, and that's probably something that I would not recommend doing. Again, to a center of excellence that has a large volume of Ross experience and the data to the long-term data to show it. In the absence of that, if you know that isn't in your wheelhouse, um, you know, I would honor the patient's wishes again because they're going to live with it as long as they, you know, understand what their life will look. And overall, I think it's pretty favorable. I mean, we have data from the COMMENCE trial, which is very promising. And even if you do have the young patient in their 30s or 40s that you can't do a Ross on and they do not want to take Coumadin, and you do a bioprosthetic replacement in them, and say they present, so you do it in a 30-year-old and they present at 50 again, and they need a another procedure. Well, that's 20 years from now, and so I don't know. Maybe at that point, valve and valves may last 40 years for all I know. But if not, you can potentially do a reoperation with very low risk, and potentially that's their last operation. Because the next time around, another 20, 30 years after that, potentially they can have a transcatheter valve and valve procedure. So that's how I would go about it.
Nikhil, first I'll address the audience just in case people are Googling right now, what is a Ross procedure? I suspect a couple of people pulled out their phone.
Absolutely.
But I
Well,
was going to ask you if it comes up much in your population, if people ask you specifically about a Ross procedure. But just for those that aren't as aware, it's a complex operation. The surgeon has to take out the pulmonic valve and then the surrounding pulmonary artery, and then is removing the patient's native aortic valve and has to replace that with the patient's own pulmonic valve. So hemodynamically, they work very well. And, you know, it's kind of mixed reports. The durability was not great, like 20, 30 years ago. And so people went away from it. But now with some improvement in surgical techniques, they're starting to do it more. And then, of course, the patient's own pulmonary valve has to be replaced with a homograft. And so it's like replacing two valves instead of just one valve. And it speaks to Matt's point. You want to do this in our center of excellence. This isn't a casual operation. This is one that there's pitfalls. You want to make sure you get this right. The operative mortality for an aortic valve replacement should be very low, like ideally less than 1% in that group of patients. Nikhil.
absolutely, Dr. McCarthy. I totally agree with everything you said. And so it's an attractive option. I mean, you know, the prototype I have in my mind is, you know, maybe a lady in her 20s or low 30s, and she's thinking of getting pregnant. She has a bicuspid valve with severe, you know, aortic regurgitation or aortic stenosis, and mechanical valve and being on Coumadin would not be a good option for her. And so this might be a great choice. And I think when you look at the studies, it's very promising. But to your point, these are really centers of excellence with relatively high volume. And so I think as a cardiologist, if that's the kind of patient I have in mind or a similar kind of patient, I would really want to seek out the surgeon and the center that where I have confidence that they have a high volume and that they have excellent outcomes before I would consider that. I don't think patients generally have heard of the Ross procedure or have a lot of familiarity with it. So it's more of a nuanced conversation. I think most people, the lay public, they say, well, am I going to get a pig valve or a cow valve, or do I get a metal valve? And so those are usually what they're kind of thinking, maybe something through my leg versus open heart. So I do think this is a more nuanced conversation, and it would be the right patient with the right surgeon, as opposed to just more of a general choice that we would be giving probably most of our patients. Is kind of the way I look at it.
It's good. Can we go to the next slide, please? And also for the audience, I want to suggest again, the Q&A is, I believe, on the bottom of your screen. So we're tracking it. And so if you have any questions, feel free to type it in, and we'll try to address that. So I guess this is, one of my last slides, and it's basically, would you ever want a mechanical valve? And I've actually asked, groups of surgeons, I'll speak to, 300 of them, how many of you at your age would choose a mechanical valve for your patient? And I'll see, maybe 30% of their hands will go up, or 40%. And then I said, well, would you want a mechanical valve? And then about 90% of the hands go down, because it's generally not what surgeons choose. And it's because of this: the higher stroke risk, higher bleed risk, the Coumadin issues. Mechanical valves failure mode is thrombosis, which is much more urgent than it is if a tissue valve gradually wears out. And you kind of burn that bridge. There's no other non-surgical option ever coming if they do have valve dysfunction. I think our question these days is really, is the survival difference for real? Matt went through some of the papers, and others don't show a survival difference. The Bodish one we just talked about. Or is it ultimately patient selection? When you've only chosen 10,000 out of 110,000 to get a mechanical valve, is it because they, had absolutely no comorbidities, and that was a better patient operation, or a better patient group? I think an important part too is, people say, well, they have atrial fib, and therefore you should get a mechanical valve. But it's now Class 1 guidelines in all surgical series that if you are operating on a patient with mitral or aortic valve disease or coronary bypass, you have to close the left atrial appendage. There's a 33% reduction in stroke by 3 years later. So it's, instantly very effective at reducing stroke. And then also do a maze surgical ablation for that group of patients. And so a lot of those patients actually come off of Coumadin, and they really don't need that group of patients. So, or they don't really need to be on Coumadin. So Matt, I'll give you this one because it's a mitral AF question. So Dr. Iacona asks, what about a 60 to 70-year-old mitral patient with long-standing persistent AFib and a large left atrium on Eliquis?
Yes, and that is someone that I see regularly, and I would definitely repair or replace their mitral depending on what the pathology is, and most definitely do a maze procedure and exclude the appendage. People say, well, they may have a really big left atrium. That's true, and there are predictors of decreased single procedural success. However, it never goes to zero, is what I always tell people. And if you can do a appropriate thorough maze procedure, I think you have a really good chance at eliminating atrial fibrillation. At least that's been my experience over the years. And if they do recur, you still have a transcatheter option to do a potential touch-up. So yes, that is somebody that I would definitely do a maze procedure on, as well as exclude the appendage.
Yeah, same here. We just published about a year and a half ago a series since 2013, for the mitral patients in particular, it was 100% of patients with atrial fib had concomitant AFib ablation surgery, and then also closure of the left atrial appendage. And what we showed is improved survival compared to a group of patients that were untreated. And that's been in many different studies now. And then in addition, we showed in the paper I just mentioned that it returns their survival to that of expected for patients that had never had atrial fib. The question is, can you take that group of patients off of long-term anticoagulation? Let's say that they're 6 months out, you do a Zio patch, or you have other monitoring, really extended monitoring indicating that they're not in atrial fib. There's no great studies on that right now. We actually just sent out a survey to large group of surgeons to see how they manage that group of patients. It looks sort of 50-50, that about half will take the patient off if they're convinced they're no longer having atrial fib and that the left atrial appendage is closed, and we're actually considering it for a randomized trial.
Yeah, we have a protocol at Michigan, and what I personally do is at about 5, 6 months after the index operation, and if they've, what we do is we stop the uh, oral antiarrhythmic, place a 2-week event monitor, and if that shows no atrial arrhythmias, we do some type of imaging to look at the appendage, either a TE or a CT scan. And if they meet all those criteria, then we have stopped anticoagulation for them. And then we follow them every year too with an event monitor from there on out. What's funny is some patients come back a year and a half later and said, "Oh, my primary care doctor put me back on, DOA on Eliquis." And I was like, "Well, why is that?" He says, "Well, because I had AFib years ago." I said, "Well, you don't have it anymore." But anyway, so I think a randomized study would really be, or some type of prospective study would be very helpful.
Yeah, I agree with that. In my world, a couple considerations. So one is, do they have a stroke because of AFib, or is AFib sort of part of the milieu that ultimately leads to a stroke? So is it causative, or is it just more of a correlation? So we really emphasize CHADS VAS score. I think the CHADS VAS score underestimates certain things, including size of the left atrium and whether someone has obstructive sleep apnea. So we could probably refine that further. I think in those cases where the patient really wants to come off of anticoagulation, an implantable loop recorder is a great idea. We do that in the office, doesn't require general anesthesia, has a battery life of at least 3 to 5 years, and it's automatically sending us a report once a month. And so we're getting a ton of data about AFib. The 2-week monitor is good, but it's limited if someone has AFib, more intermittently. And so the loop recorder is a great option to, long-term monitor these patients. But in general, if I feel their CHADS VAS score is high and maybe they have a left atrium, even large left atrium, even if their left atrial appendage has been excluded, I tend to favor leaving them on oral anticoagulation, especially because the more quote unquote newer or direct oral anticoagulants tend to have a much lower risk of bleeding compared to warfarin.
Right. Yeah, those are all good points. I do think that in the future we'll be using more implantable loop recorders. I think it makes a lot of sense to do that. There is a trial that just completed enrollment called LEAPS. It's 6,000 patients randomized in surgery over 3 years, and it's patients that don't even have atrial fib, but have a large left atrium or other risk factors for atrial fib, and so half had their appendage closed and half did not. And so that's going to be really interesting. So Nikhil, for you, is just like you said that you be careful about who did a Ross procedure. If you had a patient as described here, as a cardiologist, would you say, well, I really want to send this to a surgeon that's going to close that left atrial appendage and treat the atrial fib? I don't know that that is as, as well established as it should be. The Laos 3 trial that I mentioned, that was in the New England Journal of Medicine. So I hope that people are really very aware of that one.
I think they are, and especially at our center, that's really the standard and that's the expectation. I mean, I tell my patients, look, you're going under, we're going to do an open heart surgery. We want to do accomplish as much as possible during that procedure. And I think patients intuitively understand that and appreciate that. And so if it can be done, I think it's something I would want my surgeon to consider.
Great. Well, it's getting close to time when we would close. So I think what I would summarize this is that it's a complicated discussion. The younger the patient, the more complicated. Frankly, above age 70, it's pretty simple discussion. There'd be very rare that I would use a mechanical valve, probably haven't in 20 years in that group of patients. The younger they get, the more the discussion, and it is really about they have to live with this. And so if they have a mechanical valve, that's fine. There may be some indications that their survival is better, but they aren't the greatest data. It's not randomized data, and they will every day have to be taking Coumadin, and that is something that they need to think about with their lifestyle. So, with that, any other last thoughts, Nikhil or Matt?
No, I thought it was a great session, and I agree, and I just can't highlight enough the importance of a shared decision-making process and understanding the data as well.
Yep, you have to listen to your patient, and ultimately they're the ones that have to live with it.
And
Well,
I
thanks,
think,
everyone. Chris, I think we're going to hand this back to you from MedAxiom.
Yeah, Dr. Bossi, did you have a final comment?
well, I was just going to agree. I mean, I learned a lot listening to Dr. Romano and Dr. McCarthy. And, really my take home message listening to these presentations is that, like you said, there's no one size fits all. And just looking at age alone as a cutoff probably doesn't make sense. You have to really put all the pieces together.
Well, we want to thank you all. This has been a terrific discussion. We want to thank Dr. Bossi, Romano, and Dr. McCarthy, and Edwards Life Sciences. We have recorded this. We'll be pushing this out to all the registered attendees, and this will also be available on our websites on demand. So with that, we'll bring the webinar to a close. Thank you all for attending. Have a great evening.